but we're not moving.
Hey, everybody. Cassidy, founder and creator of the Caregivers Hub, coming to you live. Today is Sunday, January 7th, 5 p.m. Pacific, and I am super excited to have you guys here today. We have a special guest, and I'm super excited about this topic and about our guest today, because this is one that's close to my heart as a healthcare professional. If you don't know who I am, my name is Cassidy Bastine. I am from the greater Seattle area. I currently work in hospice, but I've been a certified nurse's aide for 15 years. It is the sole work of my life, and I love to share my care philosophies with you. And so on that note, what is the Caregivers Hub? The Caregivers Hub is a community for caregivers that I started almost a little over a year ago. We have 3,800 members all over the world in our group. We have family caregivers, we have professional caregivers, we have medical social workers, we have speech pathologists, we have doctors, we have so many people out there creating awareness and sharing their journeys with caregiving, whether you're a professional or you're a family caregiver. And this community was created for you. And so every single month, the first Sunday of the month at 5 p.m. Pacific, I try to bring out topics and people who are experienced with those topics to give you some insight and for us to just sit down and talk about the things that matter in caregiving. So on that note, I'm going to introduce our special guest today, Dr. Phillip D. Sloane out of Chapel Hill, the University of North Carolina. And he wrote an incredible book. And like I said, I've been doing this for a little while, and I get approached about a lot of different things, especially, on the internet. And there's a lot of great tools for caregivers out there. And my main mission is that when I bring you something, it actually benefits you as a caregiver, that it's going to help you on your journey as a caregiver. And the Alzheimer's Medical Advisor, a caregiver's guide, is one of those things. And Dr. Sloane has written this book. And you know what? When I looked at it, I thought, this is an encyclopedia. This is like an encyclopedia to me. This is every single thing that you need to know when you're dealing with caring for somebody with Alzheimer's and dementia, from understanding what it is, how it works, different scenarios. I love that you've lumped how to deal with healthcare in this, because that is definitely one thing that is, I kind of around the board. How do we get people with Alzheimer's and dementia to their appointments? And how do we deal with healthcare professionals and Alzheimer's and dementia? And all the way down to recording sheets, you guys, medications, absolutely everything that you need to know. So, Dr. Sloane, I want to know your story, how you got involved, how you became a doctor, and why Alzheimer's and dementia is your mission.
How long do you have?
We have an hour.
Do you want? Do you want the 2-minute version, the 5-minute version, the 10-minute version?
We'll tell you whatever you want to give us.
How's that?
That sounds fantastic.
Yeah, I've been doing this for a long time. I went into medicine to be a family doctor, and I didn't really think too much about it, other than I wanted to serve people and I thought it'd be a great profession, and I knew I had the skills. And I managed to get into medical school. And then when I was in residency, I wanted to do some research. And I ended up working in a unit for older persons. This was at the University of Miami. There's plenty of older persons there. And these were people who were supposed to go to nursing homes, but there were no beds. And so we had a unit for people who didn't belong in the hospital, but there was no place else for them. And so I learned a lot about aging as part of that. And at that time, not that many people knew much about dementia. In fact, I remember when I was a resident, somebody came in that clearly had dementia, and I went to my preceptor, the faculty member, and he was clueless. He could not give me any useful tips on how to deal with his family and this person. So we've come a long way since then, and that doesn't happen anymore.
Right.
But then, as I came to the University of North Carolina as a faculty member, and a nursing home in town was looking for a medical director because they had somebody who died because they couldn't get the medical director to show up and look at the patient.
Oh, okay.
Even though they came in to make rounds, they signed all their stuff, but they wouldn't see the patient. And so they came to my department, and since I'd had this background, I started. They invited me to be the medical director, and that was sort of my training ground.
Mm-hmm.
And I spent maybe 15 years as a medical director, and then I later became director of an Alzheimer's unit, and I became a national advisor for Alzheimer's care for a major nursing home chain. And then I got into doing research on specialized Alzheimer's units. We got it in nursing homes, and so it's been a lifelong career. And but I just fell into it. I think you don't plan what happens in your life. You really don't. Stuff just happens. And so I got involved in it more and more. My mother was a nurse. I'm sure that had a lot to do with it. And she ended up working in a nursing home when she forged her her Social Security card so that she could work longer than she was supposed to. And she worked in nursing homes until she was like almost 80.
Wow.
So we had this simpatico thing going on. And
right.
I guess that's kind of the medium-sized story of it all.
Well, great. That's kind of funny is because my grandmother, before there was ever such a thing as a CNA, my grandmother was providing care. So I kind of have that feeling. It's intrinsic within me, I believe. But I know for myself, it has been, I wanted to be a nurse. And once I got into the nursing homes and I started seeing what nurses were doing and also, the job parameters of what I was doing. And I found that I didn't want to stand behind a cart. I wanted to be in there. And to this day, people ask me all the time, Cassidy, why aren't you a nurse? Go be a nurse. You'd be the best nurse. And I say, I'm the best CNA. And you know what?
Yeah.
I show up every day and I provide the best care that I know how to people who have Alzheimer's and dementia and people who don't. And that is needed very much so.
Good for you. Fantastic. Yeah. The one thing we haven't talked about yet is the family caregivers, the folks who do the majority of the care.
Absolutely. And you know what? It wasn't until I did in-home care agencies and I was providing 24-hour care for 4 days a week to somebody who had undiagnosed dementia and as well as bipolar. And I did not realize until, that was almost 13 years into my career, if not less than that, before I really understood what family caregivers go through and recognize them as more than just a pain in the butt sometimes in a medical setting.
No.
In
this setting, it's a squeaky wheel that makes sure things happen. And you have to.
Right.
I really try to appreciate that on an ongoing basis. Yeah. I should mention another influence on me has been Lisa Gweither. I don't know if you know her, but she's a woman at Duke who has founded some of the early support groups for all. She's run it's now called the Family Support Group for 40 years out of Duke, and she's testified to Congress. But her husband and I went to medical school together. So early on, we began talking about families and their role because she was so instrumental in this whole field.
Right.
And she was on the group that helped write the book.
Oh, I'm so happy to hear that. Well, I guess that's what I always try to make sure that I'm impressing on our family caregivers and our professional caregivers. I really have wanted the hub to be that place where we bridge that gap, where we can start working together because hopefully you're in this industry for the right reasons and you want to provide good care and you want good outcomes for your patients and your residents and your clients. And I feel like we're in this together. My philosophy is my job is to care for my people how their facilities want them cared for, how their families want them cared for, and most importantly, how they want to be cared for. And if we could all come together on that, I think it'd be great. For sure.
Yeah. We do.
So family. Oh, go ahead.
Most people do the best they can.
Absolutely.
And I've done research. I've probably been in 1,000 nursing homes or assisted livings or PACE programs or all various types of places that serve people with impairments. And
Mhm.
most of the people in most of the places have their hearts in the right place and they're trying to do a good job. The problems are it's hard work. There's more to do than you ever have the time to do.
Mhm.
And it's stressful.
It
And
is.
and the other thing, there's a lack of education. There's a lack of support. And I think that's just the way it is. It's a way for families and it's a way for professional caregivers. And then, of course, there
Yeah.
are people who are stressed out for because they're not able to perform well, because they're
Mhm.
not educated, or they've got two jobs, or have a bad
Right.
life, or they've got too many people to manage. And so sometimes the families have to be a little bit of a nudge about things.
Right. Well, and I think that's the main thing is, and we get this a lot. I've gotten this question thrown out in the group quite a bit. If you are not physically providing care, are you still a caregiver? And
Oh,
exactly, it's a bone of contention because some people feel like they don't have a choice. And some people feel like, well, because I'm not physically providing care and I've placed my loved one, that I'm not a caregiver anymore. And my philosophy is once a caregiver, always a caregiver. Just because you place somebody doesn't mean that you are no longer their advocate. And sometimes being diligent with medical staff and, getting on top of them a little bit is about being an advocate that way.
how long can I talk about this topic? Because
I know, right?
it really is a big topic.
For
The different
sure.
roles that caregivers have, and within families, when someone's at home, or even when they're not at home, there's often one person who's kind of the point person for the care,
Right.
and that person almost always does more work, more hours of work, spends more time than others in the family. But often others in the family will have some roles that are valuable, like somebody will manage the finances,
Mm-hmm.
or somebody might be more medically savvy but might not be in town and kind of gets involved. Somebody's in the hospital, tries to interpret medical stuff. And the best families kind of work together,
Right.
but it is hard being the primary caregiver, the one who does the hands-on stuff, because it's hard to be appreciated or feel 100% appreciated because of all the little things you do.
Right. Well, I mean, and family caregivers, you're on this, like that you get on this train of care with these people and you're writing it out and you're there through the bathing and you're there through the feeding and the medications and you're there through the doctor's appointments and the ups and the downs and everything. And I know for what I see with my hubbers and also the families that we serve in hospice here in the greater Seattle area, by the time I see them, they're broken, they're tired, they're exhausted. And it seems to me that sometimes outside opinions and suggestions coming from either professional caregivers or other family members are, I see a lot of, well, my sister, has all these ideas and she doesn't really know what's going on here. But yet she doesn't think that I'm taking care of my loved one adequately. But I'm doing the best that I can, and I can't do any better than what I'm doing. And, that's a lot of frustration and stress for sure.
That does happen a lot. It's wonderful to see a family where everybody's on the same page and everyone supports each other, and the person who is the point person feels supported. But it's not easy to make happen.
Right, right. But I'm of the philosophy we're all doing the best that we can, and our best is always changing. So be gentle with yourself, family caregivers. You're doing a good job. You've got this. And the Caregivers Hub is here for you if you're not in those moments. I really try to make sure that our atmosphere is non-censored, that people have the right to come and say what they need to say as a caregiver. And for me, it's like, I'd rather you come here and say, I'm done with this shit today, than taking that out on your loved one, because sometimes that does happen. Sometimes you get in these situations and you're so tired and you're so stressed out to the max that it feels like I need something else. I need someone to help me. I need some place. And I have found that the Caregivers Hub has become that place for a lot of people.
Sometimes people want to say I'm done with this shit today, but there's nobody else to shovel it. I mean, seriously.
Exactly. No, serious. I know. Absolutely. I know. And I wish I could take all of that away sometimes. I hear you, I see you, I feel you in the Caregivers Hub and in different caregiving groups. I mean, I share to over 20 different caregiving groups, from Alzheimer's to cancer to whatever. And I mean, I hear you guys and I see you guys. I hear your words. They are deep, they are stressful, and they are very fragile.
Well, let's talk about the thing that you raised a few minutes ago.
Mm-hmm.
If somebody goes into a facility
Mm-hmm.
and the caregiver is not providing the hands-on care, are they still being a caregiver?
Right.
And the thing that comes to mind, well, a number of things come to mind, but one is that there's different types of care. And some of the care is emotional care. And when you're doing the day-to-day hands-on care, you often don't have the energy to provide the emotional care. So it turns out that one of the benefits, there are a lot of drawbacks, and I understand that, but one of the benefits of someone going to somewhere where some of the hands-on care is provided is that there's a little more time and energy for the person to provide emotional care, which is a useful. And then we all know, I'm sorry.
Oh, no, go ahead. Absolutely. Keep going.
That there's enough hands-on care and surveillance and observation to be done that however much time a family member can spend, it can be useful.
Absolutely. Well, how do I even get into this? I want to talk about the system. I feel like we have to talk about the system, Dr. Sloane, because I know the things that I see and the things that I advocate for when I walk in. I oftentimes, as hospice, what I often get is, first of all, we get a lot of people coming on services in adult family homes. And sometimes it seems like supplies are a little bit more of a motivator for these people to be on services than the actual needs for services. I mean, obviously.
Well, no, wait a second. I want to say something about that.
Okay.
Because I worked for 6 years in a PACE program.
Okay.
You know about PACE, Program of All-Inclusive Care for the Elderly? Do you know about it? It's a very interesting program for people who qualify for nursing home care but want to be cared for at home.
Okay.
And it's paid almost entirely by a combination of Medicare and Medicaid. It developed in San Francisco, but it's nationwide now. And there are programs where you are.
Okay.
But anyway, most of the people that we've served are Medicaid, and they have not had a lot of resources.
Right.
And they see any resource as a resource where they can get stuff because they haven't had very much access to things. And I'm very sympathetic to the fact that people who haven't had a lot of access to things, if they get a resource that can provide things, that's what they're going to do because it's a survival skill.
Right.
So it's hard for me to get kind of cynical about people trying to get stuff.
Right.
Because they're just trying to survive.
And I understand that.
Yeah.
I think my main thing for me, what I see is like I'll call and schedule a visit, and most of my, if not all of my adult family homes, they want me there at 8:00 in the morning. They don't want me there past 10:30. And so if I don't have room or time in my schedule to show up and accommodate that visit, it goes declined by nursing, by skilled nursing, not skilled nursing, by adult family homes. And and these are all things that I've experienced as in outpatient hospice over the last year. And one thing I thought to myself was, I understand that you want me there at 8:00 in the morning and get them up and get them ready. You don't see any benefit to me coming later because then you've already provided that care. So you don't need my care. But even if, and so I think for me, like my philosophy as hospice is the umbrella of care over care. It's not in lieu of care. And I think that sometimes in those situations, that's what it becomes, where people want us there in lieu of care. And then if that visit goes declined because I can't accommodate that, given my caseloads and my area of travel, wherever I am. I feel like my patients miss out on that extra little bump of care, if that makes sense.
Well, I can't really comment too much about it because that's your own personal journey.
It's true. It's true. So I guess my main thing is I think that at least what I have found, I think that it's hard sometimes for professional caregivers to not become jaded with this industry. Does that make sense?
Well, I think it's impossible not to become jaded with the industry.
Right.
But it's more, I think it's the situation and the industry, because the situation is very tough. Disability is tough, and the needs of people are tough. And so, yeah, and the industry, healthcare.
Healthcare.
You want to have a discussion about healthcare?
I know. It feels like it's an infinite conversation that we can have, and we can all share our frustrations about that. But we are here to talk about Alzheimer's and dementia. So, I would say I feel like in the last 5 or 10 years, there's been an explosion in Alzheimer's and dementia information and education. Do you feel like that's accurate?
Well, it's certainly been building up over time, very much so. And for good reason, because the other thing that happened in the past 10 years, is nothing in the science. And 15 years ago, I'm going to write something about this, but 15 years ago, we published an article predicting what would happen if a new drug came out that would really have an impact, like the drugs for Parkinson's, or drugs for congestive heart failure, something, or drugs for AIDS, something, because back in about 2000, they found the gene for amyloid, the gene that produces amyloid. And I thought, this is great, because about a third of active drugs work on genes. So once you find the gene, you can find a drug that will affect the gene. So I thought that by year 2010, we would have an active treatment that would really change the course of Alzheimer's disease, not just slow it down by 6 months or something like that, but really slow it down or help prevent it. And there have been over 100 drugs that have been gone through testing, and not a single drug has come out since 2002.
Wow.
So what's happened now is the field is saying, well, really what happens is the amyloid accumulates way early before you see the disease, and the tau accumulates before the disease. So if we're going to do anything, we got to go after 40-year-olds, okay? 45-year-olds, and figure out how we can change the course of that developing. Well, what that means is essentially that for the next 20 years, it's all about supporting caregivers, because we're not going to have anything new. That's what the field thinks.
Okay.
And I'd like to be disappointed. I'd like them to be disappointed, but we need resources for caregivers, because there's going to be a lot of caregiving for a long time.
Exactly. And it's just going to explode. And I think that's the number one thing at the end of the day that I'm always thinking about is how, I know for myself, if I can share my philosophies of care and a little bit of education that I can provide to family caregivers or professional caregivers, that I hope that has a ripple effect. It means that if I've taught you how to do something that's effective and works, then you're going to go and share that with somebody, or hopefully you're going to take that skill and that tool and you're going to put it in your caregiving tool belt. And then we have a ton of great caregivers. That's my dream. But I think family caregivers need so much support, and more than they're getting, so much more than they're getting.
Well, that's one of the reasons we came up with the book. And it turns out that, the National Institute on Aging, the National Institute of Nursing Research, they recognized that there was people with Alzheimer's and other dementias. They don't usually just have that. They've got high blood pressure, and they've got stomach problems, and they've got constipation, and they can't see very well, and they can't hear very well. They have all kinds of things, and everybody is different, but most people have some other things. Mm-hmm. And what they found was that most of the information was just about how to deal with the behavioral issues related to Alzheimer's, but not all the other stuff. So they gave us some support. They gave us a grant to develop materials to cover the whole gamut of things and not just the behavioral things. Do the behavioral things, but deal with all the medical stuff too. And that's how, and we then, with the help of Lisa Gweither, who I mentioned earlier from Duke, she got together a group of 9 caregivers at various stages who were all very expert. And we met with them every month and we would say, well, what do you think about this? And they'd say, well, that's a good idea, but maybe you want to do this. And so little by little, over the course of about a year, we kind of got the shape for the materials that would go into the book.
Well, I think it's I like I said, I was literally blown away. I didn't know what to expect when I first was approached about it. And I thought, okay. But like I said, I love that you go from, I mean, like I said, you guys, it's an encyclopedia, A to Z, everything in here, from creams, I mean, everything, agitation, abuse, neglect, breathing problems, constipation, cough, dental problems, everything, you guys. And I just think it's an incredible resource for family caregivers.
But we tried to make it not like an encyclopedia. We tried to make it simple.
You did.
We got a lot of graphics. We got a lot of lists, checklists and stuff like that to make it accessible.
Right. So well, I guess I don't say I guess I say encyclopedia because of the amount of information, but I like the way that it is set up. It's very, very easy to, say I'm having this issue today and open it up and say, okay, here, here's some great tips on how to deal with a head injury or hoarding in dementia. I don't know if I had $1 for every time I've cleared out a basket on a walker, I'd be a rich woman. But I mean, all of these things it's so great. I'm excited. And you want to know what I was thinking, Hubbers? I'm thinking, I want you guys to have this so much. I think I might give it away. So if you want a copy of the Alzheimer's Medical Advisor, I'm going to figure out a way to get this copy into your hand as a gift from myself to you, because I really want you to have this resource. But on top of that, I reached out to you guys for questions. And some of them, I have about 4 questions that I'd like to talk to Dr. Sloane about today. And the first one, and I thought this was an interesting question, is how long does an Alzheimer's patient live after they become unable to communicate?
Well, as a physician, I can tell you that whenever you make a prognosis, when you say somebody's going to live this long, they always live longer. And
I know.
You were wrong.
Exactly. I deal with that in hospice too, believe you me.
Yeah, well, hospice is particularly prone to that because you have to have a time limit. But try to answer the question. People talk about stages of dementia. There are various types of stages. And there's early, middle, late, which is kind of a simple way to think about it. But one of the things that's kind of worth knowing is that when you study communication, ability to communicate, it parallels exactly other parts of cognitive function. So if you take like a mini mental state exam or another examination of somebody's cognitive function, we actually did a study where it paralleled something like 98% of the time with their language, their loss of language. So when somebody reaches a point where they cannot communicate verbally, they are in the late stage of the disease. And then the question is, how long does the late stage of the disease last? Well, then it depends on whether there are other illnesses and how much, how intensive the care is to keep them alive, and what their desires are, what their advanced directives are. Because in the late stage of disease, some people would say, well, life isn't really worth living, and I really want to focus just on making the person comfortable, having them have a good time, and we're not going to pump medicines into them. And whereas for others, keeping someone alive really means a lot. And, and most people just struggle as best they can and without any clear sense of guidance, because things happen and you just never know what's going to happen. So on average, after someone cannot say a word, you're probably talking 3 or 4 years on average nowadays, because the care is pretty good in the end stage of disease.
Right.
And one of the problems that hospice professionals like yourself face is that you just have no idea.
Right.
Somebody has cancer, the tumor is growing. We can make a pretty good prognosis. We can say, the person has 50% chance of living for 6 months.
Right.
Alzheimer's, we never know until they get really sick, until they they get so dehydrated, or they get pneumonia, or something happens, they get a stroke.
Right.
Otherwise, they can just go along for a long time. But if they're not eating, then there are issues like, well, how much do you force feed them? What do you do about that? What if they're losing weight? What if they're getting dehydrated? You give them. So as time goes by, the amount and intensity of medical interventions can have some effect on the length of time somebody survives. Although interestingly, studies have shown that putting a feeding tube in somebody does not lengthen their life. Isn't that interesting?
That kind of makes me a little excited the way that I feel about it. I mean, I definitely feel like if it's going to improve your quality of life, to have a tube feeding, by all means. But if it's not going to improve your quality of life, that's how I feel about it. And maybe that's because I'm in hospice. I don't know, but that's just how I've always kind of felt about tube feedings. And, I've seen, I mean, how do I explain it? To watch somebody go through a journey to provide care to somebody with a tube feeding, and to see that lack of quality of life, and to go through that journey with them. That's just as hard on me as a professional caregiver as it is on their families.
On the other hand, when I was working in PACE, one of the first guys we had, patients, residents, we call them participants. One of the first participants we had was a gentleman who had a stroke, could not say a word, was in a wheelchair, had a feeding tube. We would put up his stuff every day and feed him. And he lived for like 6 years. And his family took care of him. And then he came to the PACE program during the day, because we had a day center. And one day, the other doctor was on call, and she got called in to replace his feeding tube. It was a Saturday night. So she makes a home visit to this person's house. The family's having a party. All kinds of people around, and this gentleman's in the middle of the party. Okay? And the point of the matter was, he was part of that family, and to that family, keeping him going had real value. And so that helps illustrate that we have different points of view about things.
That's true.
Them keeping him going had value. Now, for some people, for me, I saw that he had a lot of pain. He had a lot of discomfort, but he did recognize me. It was interesting, And so, the brain is a very interesting thing. And there's just so much we don't know. But if you get to know the person, they're a person.
Absolutely. And I think that's the number one thing that I always make sure, when I get my people, my Alzheimer's, like I said, they're my favorite. I love my Alzheimer's and dementia patients. I love to just kind of get in there and see what we can do. I mean, I have one little lady everywhere, all over everything says combative resistive to like ×3. And, when I see that, I always kind of go, there's got to be something. There's got to be one thing, and for her, it's music from the 40s. So, and not getting her in the shower, it's a bed bath, I get mixed things from that, whereas some of the professional caregivers will come in and say, well, why don't you get her in the shower? And I say, well, listen, if we can achieve the same result and not have her be hitting people and be upset, and we can turn on a little music and we can just love up on her a little bit and make her clean and fresh and all of the things that she would have in the normal shower, like there's nothing wrong with that. That is okay. And I think that, I don't know, I think that's another topic to touch on, putting them in our routines as opposed to being in their routines. I don't know.
Well, maybe we continue that because we were talking about this before we got on the air.
That's right.
And it's
bathing.
an area that's close to my heart because I spent over 15 years working with people on bathing people with Alzheimer's.
Awesome.
And I showed you this. We have this thing. It's a training program called Bathing Without a Paddle that people know about. And it's become a standard for CMS, for nursing home care. It actually is considered a standard of nursing home quality. Okay. And we recently, that was about a year ago, we were able to put it on the web for free. And so if any caregiver is interested, they can Google Bathing Without a Battle, and it will come right up, and it will show you how you can purchase this, or you can get online and do the training. And it talks about things like bed baths, and we actually studied what we call person-centered bathing. Okay. And what we found is that it really, as you said, you have to individualize it to the person, but the way to think about it is not how do I get the job done, but how can I help this person have a good experience and then get the job done. And we actually demonstrated that bed baths with no rinse soap, because no rinse soap dissolves the stuff, the dirt, which tends to be soluble in that. And you can, then you just wipe it off with a towel. And we show how to do it in the training. We actually have a video of how to do it in the training. What we found is that doing a bed bath with a no rinse soap actually is better in terms of skin condition. It keeps people just as clean. There aren't any bacteria there because we measured the bacteria. We looked for skin breakdown. We looked at all those things, and they actually scored a little better than people who got the showers. Because showers tend to be drying. And so for plenty of people, it feels good, but it's not necessary for keeping people.
I love that. So I had this lady, and for 3 weeks, and this was a woman who lived in assisted living, and she didn't actually take a shower. She sponge bathed herself daily, but she didn't actually get into the shower for over 2 years per her family. And so when we first kind of came into each other's lives, she was very receptive to it. But then finally, after like 3 weeks, she was like, nope, I'm not doing this anymore. I'm just not doing it. And so I kept trying and I kept trying. And finally, I walked in at the most prime point when she absolutely 100% needed a shower, and
bowel movement over things or something.
Oh my goodness! And not only that, she was rinsing her. She was trying to wash her pull-up in the toilet, and and automatically my brain was like, okay,
She was a little confused.
Absolutely, but also think about it this way: she grew up in an era where that's what we do if our underwear are soiled. Yeah. We wash them and we hang them. And so she was trying to do that. And so finally I said, you know what? I understand you really don't want to do this today, but I really, really would like to give you a shower. And so I just kind of took her by the hands and I just kind of guided her over there. And she gave me the dirtiest look and she said, you have been trying to do this or you've been dying to do this to me. And I said, you're absolutely right. But
maybe
you know what?
That confused, huh?
No. And like I said, she was very, very pleasant. It was just not part of what she had done for herself prior to, for 2 years, she gave herself a sponge bath and that was sufficient enough for her.
So you kept telling her she needed a bath, but she knew she didn't need one. When she finally needed one, according to her, she was glad to have one.
She was. And you know what? I even got her a dilly bar from Dairy Queen. So I left her eating an ice cream bar after a shower. So, that ice cream was kind of my motivator, but the other was an even more motivator. And,
what you can do. Yeah. We found, like you've shown, if people will bite, well, if they bite,
right.
Maybe if you give them a cookie, that will solve that problem. And we talked about being a detective in dealing with behaviors, because there's one of the things that we've learned in studying Alzheimer's is there's nothing that works for 50%, and certainly nothing that works for everybody. So formulas, it really, people say, well, this is not rocket science, and what I always say Rocket science, you just have a formula, you apply the formula, and the rocket goes up. Caregiving, you can't do that. Nobody can tell you something. Well, if you color the code the wall, does it work? Or if you make the toilet seat like a bullet, like a bullseye, are they going to find it?
Right.
There's all this stuff. You make the water blue, maybe they like to go in the bath, and none of that stuff works except in a few people. And you have to have what works for. There are a few things that are reasonable guidelines, like the relationship matters. If they feel like they have, if somebody else feels like they have a relationship with you, they're much more likely to want to do anything with you, whatever it is. In one of our studies of bathing, there's this woman who fought all the time whenever she was given a shower. She fought and she fought. And this woman who's very smart, a psychologist was working with me, she sat down there and started talking to her, and they were talking for a while and having a good time. She says, what do you say we take a bath? Okay. And when they took a bath, and it was fine.
I know.
And, it's not always that simple, but in that case, all this woman wanted was a feeling of a relationship. And this is why often family caregivers can do this stuff, manage better than someone who's a stranger and works in a long-term care.
It's true. Well, and I think, I think for me, I'm always getting down and looking them in the eye and saying who I am and this is what we're going to do. And, but I have one little man, I ask him, do you want to go for a walk with me? How are you today? And he'll always get up and go for a walk with me. And we walk straight into the bathroom. I don't say the word shower. I don't say, I'm going to change your drawers right now, down on the toilet, and we get it done that way. Or if he just stands there, we achieve the same result. But it's not a thing of like, if you're gonna walk up to somebody and say, do you want to do this? Probably most of the time they're gonna say no. At least what I've found, if you just walk in and say, hey, do you want to shower today? They may say no. I don't know. I found no is like the number one thing most people say. They're physically doing it, but they're verbally saying no.
Yeah, I've thought about that. And I mean, it's not simple, but when someone has disability of any type, the things that they have control of really become less and less.
Right.
And saying no is a way of exerting control.
Exactly.
Especially if this is some stranger coming in, and anybody that's lived a long time has learned to become skeptical of strangers.
Yeah.
We try to teach it to our 5-year-olds, but by the time you're 95-year-old or 85-year-old, you've learned that if a stranger's coming to ask you to do something, they're probably wanting to get something out of you. And the next thing you know, they're going to get you to sign a paper, and they're going to sign. Next thing they're going to get your money.
Or next thing they're undressing you and getting you wet.
Well, yeah, think about that. That's a very personal thing.
It is, exactly. And that, I think that's one thing that I always try to tell people too, is like, think about it. If they don't have that information, they don't realize who you are. They don't, they don't have the information like you and I do that says this is bathing, this is showering, and this is necessary. And then you come in and they don't know who you are. And now you're getting them undressed, and now you're getting them cold, and you're getting them wet. And think about how you would be in that position if you had no idea who this person was. They're getting you naked in the most vulnerable state that you could ever be in. Want to do what to you? No is always going to be the answer. Yeah. But it's just those little things. So bathing without a battle, Google it, you guys. It is obviously, it can be in your hands. Thank you, Dr. Sloane, for that. We're going to move on to our...
Two other things. We do have it in Spanish now, which is interesting because, for some caregivers, we've developed it in Spanish. And we have a companion thing called mouth care without a battle.
Oh, okay.
Yeah, and it's something that really is good for families because they're often trying to do the mouth care and help people.
Right.
And there's very interesting stuff from dentistry and from intensive care units that we've incorporated into that. So that's just another sidelight we've been working on. But you have some other questions.
I do. So here, I have two other questions. We already talked about bathing. We talked about, so here was just a basic one, and one that took me a while to figure out, right? Because before I started in the Alzheimer's unit, I really had no idea about Alzheimer's, how it worked, what any of it was. And here I was in charge of the activities of 30 different people, and as well as their restorative programs. And I was doing the MDSs, I was doing the admits, I was doing their plans of care for activities. And this question, what is the difference between Alzheimer's and dementia? Took me a while to figure it out, but I got it. But I want to hear what you have to say.
Well, that actually is an easy question.
It is an easy question.
Yes. But it also becomes a little more complicated because the field is changing its nomenclature, the way it names things. But traditionally, dementia is used to describe any brain disease that affects people's ability to function in terms of thinking, mm-hmm. and that has developed over time. You know, somebody wasn't born with it. And so it's not crazy. You know, we used to use the word, you know, kind of the common lay language, dementia can be crazy.
Right.
The person's demented, they're out of their head. But the dementia in the scientific way is really any kind of brain disease that develops as person gets older over time. And it gets worse over time. So the most common kind of dementia is Alzheimer's disease. But there are other kinds of dementias. There's Lewy body dementia, there's frontotemporal dementia, and there's some rarer types as well, and there's vascular dementia. And so the field is tended to use, especially the caregiving field, is tended to use Alzheimer's disease to kind of talk about all of them. But in the scientific world, we've peeled away some other kinds so that there's not as many cases of Alzheimer's disease. Like frontotemporal dementia used to be called a subcategory of Alzheimer's disease. So about 90% of the caregiving issues are the same no matter what kind of dementia is there. Right. So when we talk about caregiving, we call it Alzheimer's medical advisor because Alzheimer's is the word that resonates most with the public. Right. But in fact, if somebody has vascular dementia, or they have frontotemporal dementia, or they have Lewy body dementia, all these principles apply. Right. There are just a few nuances that we've tried to put into the book. And so the one thing I want to mention that makes it complicated is that lately, the field has tried to not use the word dementia.
Okay.
Now they're talking about cognitive impairment or cognitive disorders, disorders of brain function, and it hasn't caught on that much yet. But the field, so you sometimes you talk about mild cognitive impairment or severe cognitive impairment, and
yeah,
I don't want to get too much into the weeds of that because dementia is what most people talk about, and Alzheimer's is a type of dementia.
Right. Well, and that's one thing that I, like I was saying, over the, from the time I started in the Alzheimer's unit until now, learning that, dementia is, I think
another word for Alzheimer's. That's the easiest.
Right. Right. But there's so many more diseases that I have even noticed in the last 5 and 6 years that have been lumped into this dementia category that I would like Parkinson's and a bunch of others.
We're getting better at identifying specific kinds of dementia. Mm-hmm. And it turns out there seem to be different things happening in the brain that cause these different ones. And it may be different proteins. They may need different treatment if, when we get down to treatment. But it's all kind of at the theoretical scientific level almost. Right. And so it's helpful to have a doctor kind of identify what it is, and because there are a few things that are different.
Right. So the last thing not the last thing, but the other question that I had, the last question that I had from our hubbers was hallucinations in dementia and or undiagnosed dementia. And I understand that that's a big thing. That's a wide range of things. Hallucinations can happen for so many things, but can we talk about hallucinations in dementia and or Alzheimer's? What is kind of the baseline for hallucinations?
Well, first of all, we have to do some definition because I want to talk about hallucinations and delusions. because they're
Okay.
sometimes confused. And the delusion is when somebody interprets something in an unusual way that they see. Like one time I was working in a nursing home and I was talking to this person with Alzheimer's and he said, Indians have taken over this building. I said, oh, Indians have, I said, what made you think that? He said, well, why else are they putting all these bushes outside? And see, he had seen that they were doing some landscaping and he was putting all these bushes out there. So he figured in his own kind of, you might call it a demented way, but his delusional way is really the best way to say it.
Okay.
He thought, well, if they're putting these bushes out there, it's for somebody to hide behind. And so therefore there must be Indians out there. And so there's Indians that are doing that and they're running the building. So he saw correctly. He didn't, a hallucination is when you see something that is, you see something that's not there or you hear something that's not there. A delusion is when you see something that's there, but you interpret it differently.
Okay.
Like another time I was in a nursing home and said, there's a lot of soldiers going around here. And why was that? Because their door was closed at night and there was a little,
oh, the shadows under the door.
A little bit of light underneath it and they could see all these people walking back and forth. There was the staff, and they thought,
right.
In the middle of the night, it's got to be soldiers. And so it came from their background. And so those are delusions. Now, hallucinations are different. Hallucinations are when somebody sees something but there really is nothing there.
Right.
Or they hear something that isn't there. Hallucinations are not as common in Alzheimer's or other dementias as delusions.
Okay.
Hallucinations are more common in what we call delirium, which is a condition that is often mistaken for Alzheimer's or dementia, or that often comes on top of Alzheimer's dementia. And basically it happens when the brain is further stressed out and it will start seeing things, the hallucination the cause of hallucination that most, I should say, delirium that many people are aware of, if somebody drinks a whole lot and they're an alcoholic and they go into DTs,
right.
That's a delirium from alcohol withdrawal, and they see all kinds of stuff. They see bugs crawling on the wall, and they see all kinds of things they don't usually see. That's because it's kind of delirium. Well, when people have brain disease, like Alzheimer's or other kinds of dementias where they don't have as much ability of their brain to resist when something goes wrong in their body. Like, let's say they get a fever or they're on a drug, they're on some kind of drug that might confuse them. Those kinds. So if somebody is seeing things often and they weren't before, if they're having true hallucinations, you have to ask, do they have a delirium? And because deliriums are usually reversible. It's usually because of a medicine or an illness or something like that, you can do something about it. And so hallucinations to me mean maybe something different is going on that needs medical attention. Now, in Lewy body dementia, a certain type of dementia, hallucinations are quite common. And the thing about hallucinations in Lewy body disease is that often they start early on in the disease and the person could be walking around and they're pretty with it, but they see these things. And the interesting thing is they don't bother them that much. They kind of know that it's not exactly real. They know it's there, they see it, but it's not real. So it's a very interesting field, the whole field. And then of course, if somebody, if you are very close, let's say you've been married for 40 years and your spouse dies, often you will have hallucinations of that person in the year after the death. It's called hallucinations of widowhood or widowerhood. And it's a very common thing, and you hear them talk, or sometimes you'll see them. And it's because that person is so part of your mind that, or maybe they come back and visit you. I don't know. But well, seriously, there are different types of hallucinations.
Right.
And, I think one of the things to think about is how much is it bothering the person? And is it new? If it's new, is there some medical thing going around, or drug, or something that's affecting you, or their body chemistry is screwed up? And we can talk about the different chemicals that go out of whack.
Right.
And all those things that they might need medical attention. But if it's not bothering them, it's a little milder thing, well, maybe it's okay.
Yeah. Well, and I think that that's one thing that actually I learned from Teepa Snow. She's out of Chapel Hill too.
Yeah. We've worked together
So
a long time ago. We worked together. Yeah.
Teepa, she's incredible. I was given my facility sent me to a 3-day conference with Teepa, and she opened my eyes incredibly, and it changed everything in how I saw dementia and Alzheimer's and percepted it. And I completely lost track of where I was going with that. But I love her philosophy. Is her philosophy embraced as much as it should be? Could that be the catalyst to changing how we deal with Alzheimer's and dementia in a professional setting?
Well, I don't want to speak for her, but
Right.
from what I know about her, the message she gives is very similar to the message you give, and the message that I give, and people that I work with give, which is that people with dementia are still people, and they need relationships, they need to be understood, and they need to be loved. And it's our job to try to figure out how to help them the best and how to make their days go as well as they can.
Right.
And I think that message is coming from a number of sources. She's very good at communicating it.
Absolutely. Well, and I'm a firm believer that we are multidimensional. We require more than physical care. We require mental, emotional, and spiritual care. And the one thing I found is that once I got involved in hospice, this is where I see this philosophy very much embraced and implemented into our care for our patients. With the interdisciplinary system that we have, sitting down with MSWs and nurses aides and nurses and doctors and talking about our patients and these things. And sometimes I feel like I wish healthcare had that entire philosophy, that we could all sit down and do that.
Well, PACE does, and
Okay.
hospice does. But one thing to remember is hospice has more resources than many other places, and it's I can't. Hospice gets more resources because hospice saves money. And
Okay.
that's the crass reality of the healthcare system. And
Absolutely.
money is a big issue. And within the resources that people have, there's many adult care homes, assisted living, nursing homes. They don't have the number of person hours per client, and so they
Right.
struggle. And so hospice is a great place to work for those
It
reasons.
is.
It would be nice if everybody else could
Absolutely.
work that way. Yeah.
I know. And well, I mean, but what's it going to take in the system to change that? I mean, how much money, I mean, I understand healthcare is a billion-dollar industry, but what do we keep sacrificing for the almighty dollar in healthcare?
Well, everything it takes resources. You have to think about the resources you're using. And
Okay.
I think, if you think about like education, are the schools really as good as they should be? No, because we limit our resources there. At a societal level, sometimes we have to do with what we have, and
Right.
families are in the same situation. And a lot of families have a lot fewer resources than the average nursing home.
True.
But the resource they often have is the ability to care and individualize.
Mm.
And
Yeah.
it's there are no simple answers. There really are not. We just
I know.
in this world.
It's true. Well, I mean, my main thing is I'm only responsible for the quality of care that I provide.
Yeah.
And I hold myself responsible for the quality of care that I provide. And I try to impress that upon, my medical professional friends. We have to be held accountable for the quality of care that we provide. Family caregivers, if you are not being provided good care, it's okay to say something about it. I see a lot of people just accepting poor care because they don't think that they can do anything about it. And then they just let scenarios go by, and sometimes healthcare professionals walk all over them. And I've said it on multiple occasions. If you need anything at all, make sure you're calling hospice. And if you're not happy with your quality of care, please call us, and we will see what we can do about that. I don't know. That's where I'm coming from, for sure. Okay, so let me see. We are at 6 o'clock, Dr. Sloane. Is there anything else that you want to talk about today?
I don't think so. This has been a great conversation. You're a good conversationalist.
Thank you. Well,
it's important work.
It very much is. And, like I said, it is the soul work of my life. I love when I can communicate with my end stage Alzheimer's peeps. I'm a firm believer up until the very end, our souls, who we are in there. And I've been amazed when I approach somebody and I start talking to them at end stage when they're non-communicative, the things that they do and they say, because they actually feel like someone is recognizing them as a human being and asking them how they feel, whether they can respond or not. It's the best part about what I do. It's how I've gotten through 15 years in the trenches of CNA work. So I am so extremely grateful for your book and for what you do and for coming out and talking to us today.
Thank you so much.
Absolutely. All right, Hubbers, make sure you tune in next month, the first Sunday of every single month at 5 p.m. I don't know quite who we're going to come out. I'm working with some MSWs about some things, so we'll see what we have in store for you next month. Like I said, I'm going to figure out a way to get this into your hands, so keep your eyes tuned to the fan page and to the support group, because there will be an opportunity for you to have a copy of Dr. Sloane's book that I'm going to gift to you. So on that note, keep being the badass caregivers that I think you are, and do the best that you can. On that note, peace out and have a great month.
Thank you. Goodbye.
Bye-bye. All right, just a second.